Hi, everybody. Welcome back to the Extra Mile. It's a beautiful day in Montclair, New Jersey, and today we have the incredible privilege of walking with Dr. Bill Dahut, the Chief Scientific Officer of the American Cancer Society. Dr. Dahut is a renowned oncologist and researcher who is helping to set the vision for the world's most innovative cancer research initiatives. In this episode, we cover a wide range of topics, including the groundbreaking research the American Cancer Society is supporting, the critical role of early cancer detection, and how lifestyle choices like diet and exercise can significantly reduce cancer risk. Dr. Dahut is both inspiring and empowering because he gives all of us an inside view for how our miles and support for the American Cancer Society and organizations like them are making an impact, not only through fundraising, but also by living healthier lives to reduce our risk of getting cancer. After all, an ounce of prevention is worth a pound of cure. Huge thanks to Dr. Dahut for his leadership and taking the time to share so much with us, and also a huge thanks to everyone at the American Cancer Society for leading the charge in the fight against cancer and for giving all of us the opportunity to be a part of it. If anyone out there would like to learn more about the American Cancer Society, please go to cancer.org. Now, without any further ado, turn up your volume and turn on your charity miles and come along for a walk or run with me and Dr. Bill Dahut. Every mile matters.
You don't really know who you are or what you are until you put a really big challenge in front of you.
Fear is an asset and ally here to help you be magnificent.
This crazy, silly, stupid idea to run across the Sahara Desert.
You did make it this time, but you said if you didn't make it, you would try again and again.
Everybody's connected to nature, connected to music, to their families, and now we're going to build a world that doesn't have racism and war and starving kids.
I kept telling myself, run at it, and just keep smiling.
So my name is Bill Dahut. I'm the Chief Scientific Officer for the American Cancer Society. And in that role, I oversee both our extramural research, which is our grant funding. We're the largest nonprofit funder of cancer research outside the U.S. government. A large program of fellows in the pre-doctoral space. And we also have an intramural research program, which is largely housed in Atlanta, which includes our very large cohort studies, our work, which we look at population-based information out of a public available databases, such as our cancer facts and figures. We run our guidelines work in our journals. And I'm a medical oncologist who spent most of my career at NIH. I focus largely there on prostate cancer in my own research career.
Wow. So are you mostly a research doctor or like a practicing oncologist that, patients would say?
So I'm a physician. And in my career, almost all the work I did was running clinical trials. So when you're at NIH, and every patient you see there is on a research study. So all my work was research, but most of it was patient touching.
Excellent. And you might maybe share a little bit of your journey as to how you became an oncologist and or why you became an oncologist, and then how that led you to the American Cancer Society?
Yeah, sure. It's sort of interesting. So I went to school in Georgetown, grew up in the Washington, D.C. area. Actually grew up not too far from here, went to high school about 2 miles from here. So it's all kind of a small world, as they say. But my first medical school rotation when I was at Georgetown as a first-year student, I got assigned to oncology. I didn't even know what that word meant. I actually had to look it up in my dictionary, what oncology meant. And
you're a med student that didn't know what oncology was yet?
It was I was only been there for maybe 6 weeks, and this is the late '80s, and I don't think people use the word oncology. It's kind of funny now. It's such a common term, but I bet if you went back and saw, it just wasn't a term that people use, so it's pretty amazing, right? So I looked it up, and sort of the long and short of it, the Navy was paying for medical school for me. So as part of my time, I was up at the Naval Hospital, and they had a combined program with the National Cancer Institute. were actually, and so for me, I think I was really attracted to taking care of patients with more serious illnesses, and oncologists have a very special relationship with patients because the focus is on their cancer during that time period. So so I think that attracted that profession to me in a way, different than some other fields. And then I became involved in prostate cancer almost purely by chance. I was going back to Georgetown as a faculty member after my Navy payback was done, planning on doing some work in lung cancer. And then the person I was going to replace decided not to leave. So they said, "Do you want to do prostate cancer?" And I sort of thought about it and said, "Sure, why not?" Because I had done some as a fellow, and there was very little available for patients with prostate cancer back. This was in the mid '90s, so that's kind of. So I think it tells you that that career paths are not linear. A lot of we work with a lot of our young trainees and other folks, and so much of their life has been linear. High school, you take the right courses, you get the right college, you volunteer over the summer, you go to medical school, but having that flexibility to do things a little different is, makes life much more interesting.
Right. So, I'm really excited to speak with you today because I know that, I do a lot of miles for ACS and other cancer organizations. I know a lot of our members are walking for ACS and other cancer organizations. And, how often does an ordinary person like me get to ask about all the cutting edge research an organization like ACS is helping to support and that all of our miles are supporting? So can you what does it mean to be the chief scientific officer of an organization like ACS? And what are some of the exciting research that you guys are doing and supporting?
Yeah, so I think, first of all, it's what's really nice about being at ACS is the way we get to work with so many other great organizations, such as yours, but also, scientific partners, other foundations, other nonprofits. So I think that's one nice thing about having, such kind of a, the word's overused, but an iconic brand, shall I say. And so my role is really to really create a scientific vision for what we're doing. And, I've given this some thought, and ultimately our research kind of breaks down into four major categories. So innovative ways of finding new cancer mechanisms. So that's really discovering new targets, new drugs, new ways to treat patients. Better ways for cancer outcomes and survivorship. So we know there's over 2 million people being diagnosed with cancer every year. Many of them will then become cancer survivors. So it's really important to really understand their journey in a way that wasn't thought of in years past. A lot of work on really training the scientists of tomorrow today, because so many folks are going to have really their most inspirational ideas early in their career, but funding and other barriers right now is making things much more complicated. So we're really committed to that space. And then a lot of time and effort about the science of cancer early detection, cancer prevention, and cancer recurrence. Because I really think that's a spot that ACS is particularly strong in, because we have the ability to study the science, study the new technologies, come up with the guidelines, and then, the fact that we have an advocacy arm, find ways that folks can have that covered, and ultimately find ways that it can be implemented in the patients. So a much more emphasis, I think, on that part of the spectrum than maybe traditionally was done.
So how long have you been the chief science officer of ACS, or how long have you been with ACS?
So it's the same answer. Actually, a little over 2 years now, actually about 2.5 years. Before, so it's May of 2022.
Got it. And ACS, how old is ACS?
It's about 111 years old.
Yeah, 111 years old.
Yeah, so they were there before I got there, to put it that way.
Right. Yes. So I'm curious, how has science, or the science of that ACS is doing changed in 111 years. If you know that, you can think about the way that ACS has approached the science of cancer in 111 years.
Well, I think probably better thinking back maybe, a bite off the last 50 years anyway.
Okay.
And interesting, ACS was really the first organization to come up with doing peer review on science. So we, it's so part of our vernacular now that, peer-reviewed research, and, being a scientist, having served, reviewed multiple grants, put grants in, it's so much of our life. But ACS was really some of the first folks to come up with that NIH and others sort of modeled after it. And then the other thing, some things we're doing are somewhat similar, are these large cohort studies. So ACS will follow folks, large numbers of folks, prior to having a cancer diagnosis, and then following them for 30 or 40 or 50 years to understand what's really driving cancer. And actually, the first cohort studies was in the 1950s. It was only in men, only in white men. And it was really looking at a link between tobacco and lung cancer. And in 3 years, they found the link. And then the leaders of the study, which were all men, all smokers, switched to pipes because they thought that would actually. But and so over time we've enrolled over 1.5 million people in these cohort studies, and currently have just launched our newest, which will be 100,000 Black women. So that part hasn't, it's something we've done. And we've always had a focus also on young investigators. We have funded 53 Nobel Prize winners. 3 were awarded this year. Almost all were early on in their careers. Almost all were people who said, ACS took a chance on me when nobody else would. Because I think the fact that we were interested in funding, innovation, which isn't always funded in traditional funding sources, because people tend to be concerned about doing things that are sort of a little bit less traditional. Obviously things are deeper in basic science. I think there's a much greater bond between basic science and the clinic than there used to be. That used to be separated significantly. We now know finding discoveries in cancer can much more quickly impact patients. When I started in training, there was a huge gap between what happened in the laboratory and what happened in the clinic. So I think that's changed significantly. And then the fact on the immune system. I mean, the fact that we have immune-based treatments that are curing people with diseases that were fatal in months in the past is something else that is really markedly different.
I'm not sure how to ask this question, so it's probably not going to come out right. But when you think about that example that you gave of the tobacco detection, or the link between tobacco and cancer, and how that was discovered in 3 years, like, you didn't need 30 years to discover that link. That one came pretty quick.
Right.
And, I think maybe we've gotten to a point, although I don't know, that a lot of the obvious links for cancer would be kind of obvious to a layperson like me, in the way that, like, I've heard of the word oncology. Like, I would think about, lifestyle, tobacco, the diet, exercise. There's probably a lot of links there between, how healthy someone is living and their risk of getting cancer. Are there still links in those areas that are left to discover, or is it like pretty? We know that, like, if you eat a bad diet, don't exercise.
So let's go back to diet, right? So I think it's, we know that obesity is linked significantly with cancer, and with certain cancers more than others. So gastric cancer, pancreatic cancer, colorectal cancer, breast cancer. Other cancers, the link is not so much there. Head and neck cancer, not so much. Even prostate cancer is not quite as clear. But it's oftentimes, less clear. Sort of, is it simply calories? Is it something in the diet? Is it time of day? So I think there's a lot of science that we don't really understand about some of the broad categories which are driving cancer, even things such as obesity. And that I'm sure there are other things in the environment more broadly that we don't know, but probably has an impact. And the problem is that is much more difficult to discern because it's hard to quantify the level of exposure. So, whether it's things that we know that are carcinogenic in the laboratory and, at smaller doses, may or may not be toxic, or they could only be toxic to people that have a certain inherited genetic predisposition or combination of genes. So I do think there are other things going on. And that's why some of these large cohort studies that look at zip codes and neighborhoods and occupations, I think we'll uncover things too. So, so hopefully an answer that gave me something. The other thing I did want to mention that has changed dramatically is sort of the acceptance of lifestyle changes more broadly on the ability to have a positive outcome on cancer prevention and actually even cancer treatment. Like when I started in oncology, things like diet and exercise, we kind of get that, yeah, you should sort of do that. It's like, but there's really significantly more data that can actually this impact how well you do on treatment, how likely your cancers to come back. Things much more beyond simply, you feel a little better because you're eating well and exercising some. So I think that's important. And also I think the realization of the importance of detecting cancer early and preventing it is actually much more of the forefront in people's minds than I think it might have been, 15 years ago when really all the emphasis was on therapies.
Interesting. So I'm going to go into both of those things a little bit, hopefully maybe more than a little bit. But, with charity miles, we're all trying to raise money for things like cancer research. And that was why I started Charity Miles, was to raise money for Parkinson's research, but also, I know a lot of our members want to raise money for cancer research as well. But one of the things that I don't know if figured out is the right term, but one of the things that I kind of came to early on is that raising millions or billions of dollars for something like Parkinson's or cancer is great, but these are, $100 billion, $1 trillion problems. And there's that old saying that an ounce of prevention is worth a pound of cure. So for me, the greatest impact that I think that we have with Charity Miles isn't just the money that we're raising, but it's the way that we're changing our lifestyle to be healthier, to walk more, to run more, to eat healthier, so that we decrease our risk of getting something like cancer. So I just, but I don't have any scientific data to back that up. What does the science say about how a healthier lifestyle can reduce your risk of getting something like cancer?
Yeah, so our data overall is that about 42 to 44% of cancers are preventable by modifiable behaviors, and about 50% of cancer deaths. Now, a large proportion of that remains tobacco.
Right.
So that's maybe half of that. The rest is diet, exercise, getting your vaccination such as HPV, which can prevent cancer. But the fact, we had a drug that was out there that can prevent, half of cancer deaths. If you think about it that way, prevent 44% of cancers by, eating right, minimizing alcohol, exercising, not smoking, getting appropriate vaccinations. I mean, we'd be leaping, that would be on every single newspaper. And so, what you're doing really does make sense. So, I mean, you should feel good about it. You're right. The money is really important because it doesn't take care of the other 55% or whatever it is. Mm-hmm. But getting people conscious of the fact that they can really impact their cancer risk through behaviors that they can largely control is really an important message.
And so, I want to absorb that 50% of cancer deaths, and you said 40% of kids.
Yeah, right. Are through modifiable risk factors.
Risk factors.
Diet, exercise, tobacco, alcohol, and HIV vaccinations.
So, yeah, assuming that nobody listening to this is smoking or using, maybe somebody is, but I would doubt it. But if you're smoking, don't smoke.
Right.
What are the other modifiable behaviors would be diet and exercise, and what else?
And alcohol. I mean, heavy alcohol use does lead to cancer. I mean, so I think people are beginning to realize that obesity leads to cancer, but heavy alcohol use does increase your cancer risk too. So, and then if you're a young adult, to make sure you had your HIV vaccinations to prevent, for women, cervical cancer, and men and women head and neck cancer. So that's the other thing. So,
and is there anything more specific on the diet and exercise, like as far as what you're modifying?
Yeah. So, the actual, so the links are closest with obesity. So that's sort of step one. So to have a healthy weight is the most important. But within that, particularly looking at individual cancers, such as colorectal cancer and other factors, the things we've been talking about for 20 years, avoiding processed meats, having, healthy amounts of, fruit and vegetables in your diet, minimizing, certainly trying to reduce, processed sugars and things like that. So, but folks find that much harder to do. I think a lot of times because, so many meals an hour are eaten on the run or eaten out or, done through, some of the delivery services. So, whatever, guidelines or things we can do to sort of make things easier, we'd certainly be better for folks, overall. I mean, sort of
there. All right, go ahead.
I was just going to say the obesity epidemic in the country is like something that, we've sort of never seen before. It's changed so dramatically, the number of folks in the country with obesity compared to, 15 years ago. I mean, it's really, so that's just sort of
Yeah, I just saw today a friend of mine who's also been a guest on the podcast. He's also a mentor. His name is Sammy Inkinen. He's the founder of something called Virta Health. I'm not sure if you've ever come across Virta, but they have a program to reverse type 2 diabetes through modifiable behaviors and diet. And he posted on LinkedIn today that 3/4 of Americans are now obese.
Yeah.
So we've only got 25% to go, was his sarcastic comment towards that.
Yeah.
I feel like everybody knows, like, this is like one of those obvious things, like there's a link between tobacco and cancer that everybody knows. But so why is this such a hard thing for us to understand and interpret into our lifestyle?
Yeah, I mean, one thing, I'm wondering, without data, so take that, that's always hard to say.
Yeah.
There are probably changes in what's in our food beyond simply calories from, when I'm also older than you, when I was growing up. So it's, and so what do those changes in those food do to, increase your need to continue to eat or eat the wrong things? It's not probably as simple to see sort of as a rapid increase as the fact is we're eating so many more calories. I think there's something else going on. And that's what just always people talk about, sort of these, I think you sort of were asking about it. Are there other things we need to be studying, either driving cancer risk or maybe driving obesity risk, that is now part of what we eat routinely and is sort of buried in the fine print in some of the foods we're eating as far as processed food. So, but I just don't think we're eating 4 times as many calories as we did back in the 70s when I was a kid, and it wasn't like, we're getting Twinkies and mac and cheese and, all this other crap, so So the other question that comes up is the impact of things like GLP-1s, certainly in combination with diet. I think that's very promising, even for cancer prevention. So we'll have to sort of see how that sort of plays out over time. But
Interesting. Is there any scientific line as to what you don't want to cross as far as obesity with regards to your increased risk of getting cancer?
It's certainly it's a continuum, right? And then at a certain point, it probably sort of flattens out again. So that I don't actually have that information handy, but there's sort of, BMI is not obviously the greatest tool for lots of reasons.
Right.
But once people are sort of in the obese range in a BMI, certainly your cancer risk will go up. So,
got it. And is it the obesity, or is it the lifestyle and the behavior that is increasing or decreasing your chance of cancer?
Certainly there are aspects of obesity that are likely linked to driving cancer risk. Things, again, which your colleague would talk about, so the insulin receptor growth factor, other aspects, working through insulin, how it affects cancer. But we don't really know exactly what's driving it, to be honest with you. So what we do know is that, looking at obesity and then looking at cancer risk, there's a correlation. And then there is some science about, what's doing it exactly, but we can't say this is exactly what it is. All right. We also know that exercise independent of obesity increase cancer risk too. So even if weight is stable, regardless of the weight, exercise by itself could decrease the number of cancer diagnoses in the country. So there are separate variables. Obviously, there's interaction as we would anticipate, but there are also separate ways to prevent cancer.
So the exercise is almost independently beneficial. Yeah.
Yes.
Are there other behaviors like sleep or drinking water or decreased cell phone usage? Are there other behaviors that are being studied that you've seen have or have not?
So we are studying sleep right now, based on some work we're actually doing with Sleep Number, who actually develops, beds, as you know, looking at sort of our large cohort studies, looking at the effect on sleep on cancer risk. There's a logic to things like that because you wind up with, increased inflammation. Inflammation drives cancer. So there is a sense there. There's less data on things like cell phone risk. And what was the other question I think you asked me about? It was so.
I was just saying drinking water. I mean, all of these things are behaviors that
I think there's a little I think there's really at this point no significant linkage between drinking water and overall cancer risk. I'm sure you probably could parse it down if you had almost no water, get inflammation in a bladder cancer or something. I think potentially, but again, broadly, things that increase inflammation are things that are likely to drive cancer risk.
Okay.
So that's kind of, and you also will see some of that, with other sort of, medical illnesses or whatever that increase inflammation, cardiovascular disease, for example. The same sort of risk factors you would see for cardiovascular disease, you would see of inflammation would also increase your risk that way too.
So I've heard that in other podcasts and things that I've read about inflammation. I don't really, what is I think of inflammation like I get a bruise or I bump my knee and things get swollen, or I have a stuffed nose, I've got my sinuses are inflamed. What does that mean, inflammation? What does it mean to lower your inflammation?
Yeah, so basically, if you think of one's immune system, it's designed to fight something foreign. So if you have an infection, that's why your skin turns red. If it's infected because that's the inflammation in your knee or your inflammation somewhere else. And then there are either T cells or B cells sort of driven to that to basically fight the infection. So what that would mean on sort of a local level is increase of cells that are part of the immune system that operate at a different level. And that appears to be driving, aspects which increases one's, whether it's cardiovascular disease or cancer. So it's not as easy to sort of quantify as we'd like to. And again, the term is sort of thrown around in a lot of ways. I think as you're perceptively noted, that's very nonspecific. But there are sort of at least aspects of the immune system that one can either see at a biopsy or measure in the blood that shows, changes in the immune system.
So this chronic inflammation is one of the drivers of cancer, or is the chronic inflammation one of the symptoms?
It's one of the drivers. Yeah. So, basically, if you give an example, like if you just basically took your arm and all day long you rubbed a stick on it day after day after day after day, sort of that inflammation over time, could potentially lead you that one area. This is all we're talking like maybe years ago. Could actually you could see changes in the skin, changes over time, could actually lead then to cell damage, which would then increase the risk of cancer in that area. So again, that's sort of about it. Chronic stress, chronic inflammation, does increase the risk of cancer.
Got it. And then so things that reduce that chronic inflammation obviously reduce your chance of getting cancer.
Right. So that's exercise, jumps out there, right? Obviously that is certainly one. And then sort of the way your body reacts to obesity, again, driven through, increased insulin level, and then sort of the whole metabolic pathway, are other aspects that certainly can drive, cancer risk. So as opposed, and then you wind up when you get, carcinogens, like in what's in tobacco, again, you wind up getting inflammation, stress of those sites. And then that's not the whole reason, because you see other aspects sort of in DNA, but that's also something else that, broadly will change your cancer risk.
Got it. Now, one of the things that my doctor once told me is that because I run a lot, that the impact of the running, I can't remember if it's sympathetic or parasympathetic or whatever that is inflammatory, and that it would be important for me to balance that out with something like yoga, which is the opposite of sympathetic or parasympathetic, whichever one running is, to kind of lower the inflammation from the running. Is that doctor just kind of being general about it, or is there something to that?
I think that probably makes sense. I mean, like any sort of exercise, it's good to have some balance in what you're doing, so whether, the exact reasons why, but I think that's certainly, the CrossFit, everything else probably sort of makes sense on sort of general health. So I think there's at least sort of not wrong with it,
Got it.
Say what it was. So.
Okay. And then, all the time in like popular magazines or websites or blogs, they always have like top 5 foods that'll reduce your risk of getting cancer, or you should eat blueberries or this, or, because is there something to that where there's like a specific food, or is it just generally eat healthy?
I think it's generally eat healthy. I mean, certainly it's so just so you know, clinical trials for cancer prevention that have tried to pull out what was important about the dietary about something out of the diet have often not been particularly effective. So, for whether it was vitamin E or vitamin D, and so often when they were studied for cancer prevention and even a randomized trial, sometimes actually the vitamins led to more cancer. So it's probably something about the foods itself rather than something that's isolated out of the food, not in that same, dietary milieu or combination, which I think is sort of interesting too. So, because back in the 90s and afterwards, there were many sort of large cancer prevention trials looking at vitamins, and they really didn't have the result that people would sort of hope they would have.
Got it. So maybe let's just switch gears a little bit then, because the other thing that you mentioned was early detection.
Right.
Seems like another no-brainer to me. Like the same thing, like the link between tobacco and cancer. Like, obviously, early detection seems like a positive thing to increasing survivorship, but I guess what does the science say?
Yeah, well, I think so to start off with, I do think early detection is important. I do think that early detection is the way we're going to decrease the number of cancer deaths.
Okay.
The issues you sometimes run into is that, first of all, the studies show that in particularly a screening test or a test for early detection take a long time to show benefit. And then also, there's always been a tremendous concern about false positive tests. And false positives for the anxiety for the patients, for additional biopsies, and then, ultimately for cost of the system. So the medical community, probably rightly in some ways, probably not, maybe it's been overreaction, have been sort of very hesitant oftentimes to recommend early detection work or screening tests unless there are large studies oftentimes that showed an impact on how long populations live. And those studies might take 30 or 40 years, depending on. And, one thing we were saying is, 600,000 people in the U.S. will die this year from cancer. If you think about that, that's a baseball stadium, every month. And so whatever we're doing now, isn't working well enough, right? So and there's a lot of new technologies out being studied to look at whether blood-based testing or testing you can be done at home or multi-cancer testing where you can test for multiple cancers. And so we're very supportive of really diving deeply into that science. And, when we see evidence of, true patient benefit and FDA approval, to having a pathway forward for those things to be supported. But others are much more cautious and really want to wait until, there are very large studies, which we're just concerned it's just going to take too much time.
Kind of like, we're doing the studies, but there's not really that much of a downside to getting early screening and probably some good upside. So even before we have the data, you might as well get screened.
Well, I think we'll need, what we call intermediate endpoints that show that there's a benefit for a patient, even before it may not have the final data that was traditionally used. So I think that's one thing we're looking at, for a patient, finding a cancer earlier, if it could prevent metastatic cancer from developing, or needing chemotherapy, even if maybe over time they wound up living the same amount of length because they had a heart attack or something else, I think that would be important for most patients to sort of avoid, an advanced cancer. And so how to sort of quantify that in a screening trial, I think is something we really want to take the lead on. So
I never even thought of what is the risk of false positives? What is the downside? Like how often does a false positive happen? And then what is the real downside of that?
Well, so I think you bring up a great point, because I think from a patient's perspective, many patients would be willing to take sort of the risk of a false positive if they knew that they could find a true positive, which could allow them to live a better life.
Right.
So, a lot of times, women, when they have mammograms, will have something abnormal on the mammogram. They'll get a call. Well, they need to go back for another mammogram.
Right.
And then have to have a biopsy. And that, oftentimes the biopsy won't show cancer. And so that's sort of the, this emotional roller coaster, the pain of a biopsy, the cost of a biopsy potentially, all for something that was not cancer. And so the more you do screening, the more you'd have to do these testing. There's some economic aspects. There's sort of the, other aspects of that too. And when I talk to patients, and I'm interested in your perspective, yes, those 2 weeks or so when they don't know about what they have, is not, could be incredibly stressful. And then assuming the economic aspects are covered in a way, which is something we would advocate for
right.
Sure. Then once they know they don't have cancer, they've moved on.
Right.
This is good news. I'm glad I had the test, even though I'm glad I don't have cancer, and they're not like dwelling on it. Oh my God, I had to go through a biopsy I didn't need. So
right.
I think sometimes folks in the medical scientific field are more concerned about the false positive than patients are. The alternative is maybe I found something that now can be treated and cured, that if I had not been screened, it would have been incurable, which is good, is the other sort of way to look at it. So,
yeah, I mean, on an individual level, like, is it my call whether or not I want to take that? Assuming that the costs are covered, which is like a separate thing, which I would ask about in a second. But like, I could say, like, look, like, I want to get screened. The doctor's like, don't get screened. We don't want to give you the chance of a false positive. I could be like, look, I'd rather have the chance of a false positive, sit with that for 2 weeks. And I assume, like, you don't just like get the test results. You're like, hey, you got cancer. We need to give you chemo today. There's probably some like time period where they do another test to confirm that, right?
Well, you might have a real positive.
Yeah, and it might be a real positive.
Yeah. And so, in this country, screening tests, some in general, some are covered. Mammography is covered, colon cancer is covered, lung cancer is covered, screening, all within parameters that are either approved by Medicare or through something called the U.S. Preventive Task Force, which is basically, has worked with the government. They're not a government agency, to sort of come up with cancer guidelines. And then based on that, there tends to be coverage. American Cancer Society also comes up with guidelines. Our guidelines are oftentimes before the task force guidelines. We were really much earlier on in reducing the age when people should have, colon cancer screening from 50 to 45. And the other thing about any screening, we think it's really important that there is coverage then for the next steps along the way. So, if you have a mammogram, but there's no coverage for your biopsy, it's going to be any good. The same thing with colorectal cancer. So, as much as possible through that continuum, not just simply the test itself, but what needs to be done afterward needs to be covered. Otherwise, it doesn't really have value for people.
All right. So, brass tacks, what are the screenings that people should get, and when should they get them?
So, right now, basically, women should have, first of all, we recommend everyone receives an HPV vaccination when they're, in their early teens or even as early as 9. And then starting at age 25, they should be tested for HPV. And if they're HPV
every year,
every 5 years, if they're negative, they've been vaccinated. So again, and then basically there are now tests that are approved for self-collection in health systems, and we hope at some point they'll be approved for self-collection at home, which I think is really big improvement. Mm-hmm. Breast cancer, we recommend starting at age 40. You should certainly consider having mammography, but certainly everybody by age 45. And I think one thing I want to emphasize is this is women at average risk. So if you have an inherited genetic mutation, or if you have a strong family history, You should certainly not wait until these guidelines. And really, over time, guidelines should really be precision-based or personalized. You probably should be screened differently. But so then we recommend, yearly mammographies until you're age 55, and then you can go once a year or every other year. Postmenopausal cancer tends to go slower. You could go every other year or once a year. Colorectal cancer starting at age 45, you should undergo either a colonoscopy, the Cologuard test, or a FIT test. If FIT testing Cologuard, which is the at-home testing only if you're low risk or have never had a polyp, no family history. And then those tests are usually the home test every year, essentially. While the colonoscopy will depend on what the colonoscopy says. It could be done every 5 years or every 10 years. Prostate cancer, depending on your risk, somewhere between age 40 and 45, you should begin to talk to your doctor about whether you should get the blood test, the PSA test. And then certainly everybody by the age of 50 should be talking to their doctor about the PSA test, which is simply a blood test which tells you your risk of cancer. And then those who have had a history of tobacco use, 20-pack year history, which is, calculated on number of packs times the number of years, so 1 pack a year for 20 years, or 20 packs for 1 year, starting at age 55, should undergo a yearly CT scan of the lungs. So I think those are the screening tests that we would generally recommend and then generally would have coverage. But again, if you're at higher risk for the reasons that we talked about, you certainly should talk to your doctors about being screened earlier. And, we are seeing more cancer in folks under the age of 50. And so people shouldn't hesitate to be seen if something they find abnormal. And if they're told you're too young for cancer, go see somebody else.
How about skin cancer?
So skin cancer, I think we really recommend certainly that folks who have ever had a skin cancer should certainly, be seen routinely by a dermatologist. We don't have, hard evidence that a routine skin examination, changes outcomes, but certainly it should be done in every one of your physicals. You certainly should be careful for yourself. And if you're at higher risk because of family history or significant sun exposure in the past, we certainly encourage you to talk to your doctor about that too.
And then what do you mean by higher risk? And I ask this because I feel like we're all at higher risk these days. I mean, you talk about family history, with the prevalence of cancer, like who doesn't have cancer of one sort or another in their family? And even today in beautiful Montclair, New Jersey, I'm walking around and it smells like smoke because we've got forest fires, 50 miles from here, there's some forest fires and the whole town smells like smoke for 3 days. So aren't we all just like living in like a general state of elevated risk?
Well, yes, I think it's where the risk is high enough that it would trigger the same sort of screening test that we do for people, which we are currently calling average risk. Okay. So that would be, usually it's a first degree family member in that cancer, so breast cancer, lung cancer, colorectal cancer, prostate cancer. If you know you have a mutation like the BRCA gene or Lynch family, that increases your risk. But I think you're right, and I think it doesn't account for most of the cancers that we know about. And what you really, I think, need and what we'd want to have, and one thing is something that's really easy to just say, should I do something that's harder to do? Like if you do something at home, spit in the tube or swap something and send it in and say, okay, based on this, you should probably do a test. That would make it easier as opposed to everybody getting a CT scan or an MRI or something else. And having sort of a large funnel of something that, again, would have more false positives, but would be easy to do, but that would then push you down into something that was, more invasive. So that's what we should get in screening.
Okay. So I know we have a little bit of time left, maybe 10 minutes. Real quick, a lot of this sounds like the obvious stuff. I'm curious if you could share maybe, one or two of the more cutting edge, non-obvious things that you're working on scientifically.
Let me think about that. So I think some of the things scientifically, this is, I guess, a little bit sort of the term that's in probably every podcast is sort of the AI word.
Okay.
But basically, plane traffic here.
Yep.
But basically, using AI technology, when you have a colonoscopy, we'll be able to light up the polyp so the doctor, when they go through, can actually see where to go and biopsy. And so that's actually a fairly cool thing. And also, based on simply looking at your slides from a prostate biopsy, we'll be able to look at the slide using AI technology right now and tell you whether or not which of your treatments you should get. So the advantage of that is those slides are all digital, so you can be in a small rural hospital and, away from the smoke, and you can go ahead and send it off to a tertiary center. They can go ahead and look at that, overnight and say, based on this characteristics, if there are two treatment options for somebody, we can tell you which one to get. So I think that's one thing. And then we are sort of delving deeper into do what we call payloads that attract the cancer cells. So cancer cells have proteins on the outside of the cells. And so now there are drugs that basically will recognize those proteins. And then on the other side of the linkers, we would say, it's attached to a toxin, like a small little bomb. So basically, we can now actually, with some cancers, infuse an IV, something that attaches to something specific to a protein on your cancer. And on the other side of it is a very specific chemotherapy or radiation or other toxin that directly treats that cancer. So as opposed to just getting something that goes into your blood and it's relatively non-specific, this will only go to those areas where the cancer is. And then it can be much more targeted and much more direct. So those are actually in the clinic, and I think they're called ADCs, and I think we're going to see more of those coming out in the future. And then we continue to do stuff in the immune system. The mRNA vaccines are being tested to look at ways to prevent cancer from coming back. So you, again, look at what we call an epitope or something unusual to one's cancer. You can then develop a very specific vaccine for that cancer. And then using the mRNA technology, you can inject the patient, and then if the cancer cells start to come back, it immediately recognizes it. Works much better immune system when you have fewer cancer cells, so it's more targeted. So I think that's, again, another way, sort of precision-based treatment that I think actually has some potential to have some impact.
That's exciting. Well, I appreciate you sharing so much with us, and I very much am grateful for the work that you and everyone at ACS is doing to lead the charge here. Are there any kind of final calls to action that you want to make to people walking and running with us right now?
Yeah, I think first though, I think it's really important that you sort of look at your own lifestyle and know that you can actually change things that have an impact. I think that's really important. Things you talk about, the modifiable risk factors. Again, be aware that that cancer is really multiple diseases, not just lung cancer, breast cancer, but go within those. And that because of that, it's probably unlikely we're going to have sort of one treatment to treat everything. But we're all becoming much better at targeted therapies for these individual cancers within a cancer. And I think that's where we're going to have our greatest impact. And then, get screened, do what you need to do, follow don't be afraid to get the test, and be aware. If you find something earlier on, it's much more likely to be treated, much more likely to have a good outcome, and to sort of normal life. And I'm a big cyclist, so do whatever.
Yeah, I was going to ask about that. I forgot to ask about your cycling.
Whatever you'd like to do to makes you happy, and it definitely will really improve your own quality of life. So,
do you have any big cycling events coming up? Forgot to ask.
It's getting a little cold for that in the East Coast,
Yeah.
The last one I did, we did a century maybe about a month or so ago in Virginia and Fredericksburg. So that was
nice.
Not so bad. Yeah. So and then we do a couple of ACS has a couple nice ones. They one, I don't know if you do any cycling. They do a real nice one from Philadelphia to the Atlantic City area. They block up the road. You go over the Ben Franklin Bridge early in the morning. Pretty easy rolling road. It's the bikeathon there, and then some big events in the rest of the country. So I do one in Ohio in 4 days, which is pretty fun too. So
is that the Pelotonia that you do in Ohio?
It's actually called. We certainly work with the folks at Pelotonia. It's called the Pan Ohio Ride, which is actually a 4-day ride. Incredibly well supported. So and it's funny when everyone's riding for cancer, it has a different feel because everyone's been touched by it. So.
Right.
So if any of your listeners want a great bike ride, look for the Pan Ohio Ride, which goes from Cleveland to Cincinnati. So it's
wow.
You get to see parts of Ohio you probably didn't know existed. But
Excellent. Well, thank you so much, Dr. Dahut, for everything that you're doing, for being so generous with your time today, as you're sharing so much with us. For everyone out there walking and running along with us, I hope that you enjoy this as much as I do. Every mile matters. Thank you.
Yeah, everyone. Yeah. Thanks a lot. Appreciate having it on today. Take care.
All right. Have a great day.